Hi, everyone. We are going to continue with the second panel, which will be led by Ashley Jackson. I'm looking at Lima. And welcome back, everyone. So the second panel will be about policy and partnership for digital innovation. As you can see, it has been cited during the first panel multiple times. And Ashley Jackson is the lead of Path Global Sexual and Reproductive Health team, and have been supporting equitable access for SRH innovations, from youth-powered program to contraceptive technologies. And before, she was with PSI, among other multiple organizations. Okay, so Ashley, over to you.
Thank you, Doreen. Welcome back, everyone. So we've been hearing about how the digital age in which we now live is evolving fast, and this brings enormous opportunities, like all of the innovations we heard about during panel one. And we need policies that can help these digital innovations have an enabling environment, help the innovators understand what is allowed, what is off limits. And we also need policies and regulations to protect consumers, too. There are a lot of risks out there, risks around misinformation, data privacy breaches, fraud and counterfeit products or poor quality products and services for products sold online. So we're wondering from this panel that we'll hear now, what are governments doing to keep up with the digital transformation? How are they using policy, regulations, and partnerships to leverage digital innovations for good while also protecting consumers? Panel 2 will feature a public-private partnership in Thailand, telemedicine in Ghana, a 5-country review of the policy and regulatory environment for digital FP innovations, and finally a 3-country review of the policy and regulatory environment for digital health innovations in Francophone West Africa specifically. And our format will differ a bit from that of panel 1. After presentations by our first 2 speakers, we'll open the floor for questions from the audience. I'll kick it off with just one question, and then we're looking to have the audience ask questions. Then we'll move on to our next 2 speakers, before once again asking the audience to share your questions or reflections. Our first speaker is Dr. Anup Jayasamran, who is the chief of the Family Planning and Reproductive Health Unit in the Department of Obstetrics and Gynecology, Faculty of Medicine at Chulalongkorn University in Bangkok, Thailand. Our next speaker will be Dr. Helen Blackholly, a Vice President and Director of Technical Services for MSI Reproductive Choices. Then after we have the questions for those first 2 speakers, Vaibhav Ampur will speak. He is the National Program Manager of Family Health at Path India. And finally, we'll have Nene Fofana, an entrepreneur and a global health advocate who is currently the Executive Director of Africa Forward Advisory and the founder of the Africa Forward Foundation. All right, I'll turn it over to our first speaker, Dr. Anup. Welcome.
Sawadee krap in Thai. And thank you, Ashley, for your nice introduction. And first of all, sorry for me, to dress too formal for this workshop. I forgot that this is Sunday afternoon in Pattaya city, so tomorrow I will dress more casual, I promise. So my talk will be the policy and partnership for digital innovation, emphasizing on the public and private partnership, or what we have done in Thailand, just an example of what the government, Ministry of Public Health, have working together with the private sector, with a pharmaceutical company in our country. Why do we need, the partnership, particularly in terms of the digital, digital way, and how do we, have done, and what is that? So start from why. I think, as all of you here may aware, Thailand has a very low fertility rate at the moment. We have, two success. In terms of family planning, now we have a very low fertility rate, but we still have some problem with the adolescent unwanted pregnancy, which is rather high. At the moment, Thailand adolescent birth rate is like 2 times higher than these of the East Asia Pacific average, and we try to bring this down. And we all know that digital is key trend around the world, not just only in Thailand. And this figure show you that 80% of Thai population, among like 70, we have 70 million population at the moment, 80% use internet. And around 80, a little more than 80% are active on social medias, any social medias, Twitter, Facebook, Line, Instagram, and so on. Everybody in this country, we have a mobile, and a lot of people have more than one, more than one mobile phone, with them. And what we have done is to integrate the digital way into the solution we call the Teen Club. Teen Club Thailand, we use the existing platform, which is very popular in Southeast Asia. We call Line, L-I-N-E, Line. It's like WhatsApp. For those of you who are not familiar with Line, Line is like a platform for communication among people. And we have used the Line official account, which you can accept millions of users to be your friend in this under account. And you can do a lot of function there, like broadcast, personal communication, and so on in this. And for the Line official account that we named Teen Club, this is a platform for information, like you broadcast the information about family planning and reproductive health there. And you can do the consultation as well. One-on-one consultation through this platform. And also the users of the Line official or member of this account can find the portal for service, can find, which clinic or which hospital is close to their residents as well. A lot of function in there. The Ministry of Public Health, working with the private, pharmaceutical company, has launched this project a couple years ago during the time of the COVID pandemics. We don't have much of the followers at the moment because of the limitation in terms of the roadshow to the schools in the country. So actually, if not because of the COVID, the project, they plan, to do some roadshow throughout the countries, to get more involvement and more members of the teen or the school children to this platform. Now we have up to October this year, we have 52,000 followers, and among these we have a lot of consultation as shown in this, like the pregnancy related, family planning, counseling, unwanted pregnancy, and so on. Even some other matters like the relationship with the partners also, in there. And so I just want to share with you that the Ministry of Public Health in Thailand is open for collaboration with the private sectors and try to introduce the digital way of providing information and consultation in terms of reproductive health. Thank you.
Thank you so much. Now I invite Dr. Helen Black-Hawley to speak on behalf of MSI Reproductive Choices.
Thank Thank you, Ashley. It's a great pleasure to be here. So, and I know I've only got 6 minutes, so I will move at pace. I'll be looking at policy and particularly client trust when it comes to acceptance and adoption of telemedicine and mHealth. I just wanted to start off, actually, if I could go to the next slide, please, on a little bit of understanding around our contact centre operation, which is doubling, and it's doubling at pace. We have 300 agents working in 33 countries. We have nearly 3 million interactions. The mix of those interactions is changing now. Nearly 4 in 10 are actually coming in on social media messaging platforms. And you can see how they funnel down into referrals and service uptake. But a reason for sharing that is because you need a functioning infrastructure to take advantage of opportunities. And if we go to the next slide, please. The biggest opportunity that we have had, and it's created a huge burning platform, was COVID-19. It actually meant that governments and partners had to take action, and they had to take action fast because there was a critical need for it. And if I show you the UK numbers here, MSI Reproductive Choices handles nearly a third of all UK safe abortions, 400,000 calls a year. And that infrastructure was in place, which enabled the UK government to take a decision. Do we enable telemedicine, yes or no? If we don't, there's 60,000 abortions, where do they go? So the decision was taken fast, and within 1 week, the UK had a fully functioning care pathway for women. The process meant that actually service improved, because if you think about it, we reduced waiting times because there was hybrid working. There was improved safeguarding. You don't have to go to a clinic to get a service. And for some women, that was critically important. And there were no adverse complications. So as a model, the government saw the data, they saw the support, they saw the demand from clients for this. And working with critical stakeholders and key bodies in the UK, that has now been enshrined in UK law, that there will be and is the provision of telemedicine. It can only be taken away by an act of Parliament. That would have taken years probably to solve. Yeah? So burning platforms are important. If we go to the next slide, it's not just about countries like the UK that can move fast. It's also countries like Ghana, who again were experimenting and operating with a telemedicine model, but they put it into action with the government again in a month. And that's because the need was there. And if we go to the next slide, what you can see is that clients are satisfied and they trust it. Once you have a telemedicine discussion, 40% of those calls turned into a consultation. And once booked, nearly 9 out of 10 of them took the service. What's interesting for that, the thing that drove the demand the most was that good old friend, our mobile phone, social media, and direct web adverts. This was the way to connect with women and drive women to the contact centre. So they knew where to go. They were empowered to find information. And again, high client satisfaction. 99% said that it was good or very good. And we look at net promoter scores, and we had nearly 80% on a net promoter score. And when you look at the UK results, it was really stunning as well. 2/3 of the women who'd taken that telemedicine service said, if I was in this position again, I would use this pathway. I would not use face-to-face, as in a clinic appointment. So you are really seeing a change, a groundswell where women are able to actually take far more control through this route. E-health, therefore, is a phenomenal enabler. You have an infrastructure, but please let's not forget the role of the person, people. Chatbots will not take over the world on dealing with this. What we see is when somebody comes to one of our contact centres, through our different routes, through our multi-platform approach, what happens is they eventually will talk to somebody, and talking to somebody improves that care pathway. Their satisfaction levels go up when they actually go into a clinic, and they're more likely to recommend to somebody else. So that becomes a really powerful way of changing and improving the care pathway and client satisfaction. The other piece that was also important is it allows women to talk about the methods that they might want to be considering. And by talking to somebody, what happens is they can ask more questions at the contact centre. So by the time they come to take their preferred method, what we see is a higher tendency to want to take long-acting. And that has come as part of that conversation starting early. But we can't do this on our own, and we have no intention of doing this on our own. We can only work in partnership. And one of the key takeaways from the first set of speakers for me was actually how many organisations are operating in this space already. And we, in some way as a sector, need to be able to join these up far more fully in order to be able to give a woman information, know where to go, and a referral network. So we're doing this through a variety of partnerships, and I'd like more partnerships, so that we can have a really integrated journey. And if you then come down to some of the key government and operational implications of all of this, you can see that governments, like the government in Thailand, like the UK, like Ghana, like others, are taking action. It is a method that can work, clients trust it. But to Ben's point earlier, think about the business model. Somebody's got to pay for this. So operationally, we see the expansion. We know that data is important to actually get more governments to think through this and be reassured. The bit that we haven't spoken about so far is also healthcare professionals have to be on the journey. They have to see this as a way of augmenting their service provision. It is not instead of. And we have to have interoperability in technology to allow all these wonderful platforms to talk to each other. So from a policy and regulation point of view, if we haven't got a burning platform, we need to create some of them. We have to pilot and test. The Ghana model still doesn't cover all its costs yet. We've got to figure that out. Consistent regulations. Please let's incorporate this into health insurance schemes. And can we make sure that for the future generation of doctors, pharmacists, new healthcare professionals, it's built into their training. And then I hope that we can all have the same vision that we have, is that a woman is never more than one contact away or more than 1 hour away from a safe service. Thank you.
Thank you so much. I have just one question to kick off the Q&A, and then we'll invite the audience to share your questions or reflections. We'll start with Dr. Anup. My question for both of you is, what is one action that governments can take in terms of policy or partnership to enable digital solutions in the private sector?
Thank you. For me, I mean, I'm representing both private and public. I mean, for this talk, I mean, if I am a private sector, I would love to see the policy from the government to promote the digital or telehealth service. I think, I mean, our mission will be the same, is to provide easy access to sexual reproductive health, not face-to-face, not just only face-to-face, but remote service as well. I would love to see some of the regulation that would allow the private sector to provide telemedicine or telehealth, I mean, legally, not like underground or borderline legal at what we have done at the moment. This is what we love to see. And second thing, and the policy to open for more collaboration between public and private. So, I mean, all you know that for government things or public things, a lot of steps towards the budgeting and to do something, I mean, you need to follow many steps. And you know that digital or innovation, I mean, changing rapidly. And the government way or the public way could not catch up with that. So private, I mean, can add up on this and open for collaboration. Thank you.
Thank you.
Thanks, Ashley. It's a good question. The first thing I would say, and it's rather similar, is test. Work with governments to actually define and test a model. and do that in partnership with private sector providers. Use that data to then actually decide whether this is actually making a material impact. I would be amazed if it doesn't. So test is the first thing. The second thing is very much something that I'd like to reiterate what Ben has talked about, which is don't go into it unless you know how you're going to fund it, or have some hypotheses around how you're going to fund it. And too many are experiments with a bit of a bridge, but let's hope we get over the river and that it will work out at the other end. It needs to be more thoughtful than that. And again, understanding the revenue stream that will actually enable that to continue. So they're the two key takeouts I would take, Ashley.
Wonderful, thank you. Would anybody like to ask a question? Yes, please. I think you can come to the mic there, or do we have one to pass? Okay. Thank you, Doreen. Well. No.
Now, does that work? Great. Okay. My name is Yasmin Chandani from In Supply Health. Thank you very much. That was really interesting. I have sort of a question and a comment. Maybe the comment first. We're working in Kenya and trying to, our role is on the supply side to try and increase access to family planning, reproductive health through the pharmacy channel. And, you know, the comment is, completely agree with what you were saying, your takeaways from the more, you know, the earlier session about trying to integrate and connect all the dots. We're working with Nivi, but I think to get, you know, the pathway to getting the client in the door and getting them access to the contraceptives is quite complex. We're trying to work it out. So to my second question, we are trying to understand, there are a lot of telemedicine providers in Kenya, and one of the things I think that is a little different from what you were saying in Ghana was, in Kenya there's still a lot of trust issues around accessing telemedicine services, especially around consultation. And so I'm wondering if there were lessons you have in that, because I think in Kenya we face trust around who's at the end of the line, is it a qualified provider, both on the, as we try and connect pharmacies with those telemedicine providers, and even from the client side, trying to understand, you know, can they have confidence in what that person on the end of the line is saying. And then on the other side, it's as you said, you sort of build client trust through quality connections. And once a client meets someone who gives, you know, when they go in and actually speak to someone, that builds confidence. But again, you know, the pharmacy sector is so varied. If you could speak a little bit about some of the lessons you may have learned, that would be really helpful. Thank you.
Sure thing. I totally agree. It's complex. Doesn't mean to say it can't be solved. Yes, trust issues are bound everywhere. We see the same thing in many markets. Let me give you a couple of practical examples that we do with our contact center agents. They're thoroughly trained. One of the things that they have to do is they have to say, and it sounds so simple, but you have to say to people, everything you tell me is completely confidential. But you don't just say that once. You have to say it at least 3 times. Because people have actually steeled themselves, right? They've made themselves be very brave to make that call. We should never underestimate how difficult it is to make that call, which is why they don't come to us via voice first time often. They come in through Facebook, they come in through WhatsApp, and you're seeing our contact center agents having a digital conversation first, and they're building that trust up to the point when they can say, would you like to talk to me? Everything you say is confidential. You keep saying it, you keep reiterating. We train them in values clarification. Exactly like DKT as well, we have supervisors that listen. We have qualified providers. We also have some pretty snazzy data now that we can analyze our contact center agents on to see their performance and actually cross-reference that as well. Ultimately, if you have a great client experience, and let's face it, this is a pretty challenging time for most women, even if they're just phoning to talk about contraception, which is a lot easier a conversation compared to a safe abortion. You have to show them the pathway, and you have to acknowledge that they have fears and concerns, and that builds huge trust. So there's lots of practical things that can happen apart from, of course, the system side, which is actually making sure that that data is locked down and supremely safe. I don't know if I've fully answered your question. I'd love to talk more at this. It's a really interesting area, building that trust. Thank you.
Yeah, Dr. Allen.
Yes, can I add more on building trust? For the experience of what we have in this country, in Thailand, the Ministry of Public Health gained a lot of trust in Thailand because we provide a very good healthcare service. So, I mean, if you're gonna think about trust, you need to partner with the government, particularly the Ministry of Public Health for our country, for Thailand. I'm not quite sure whether the situation in that country will be the same. So if you are just only a private sectors and opening and doing things in terms of the telemedicine or teleconsultation, the trust will not be as high as you partner with the government. Like what we have done in Thailand, we have the private sectors providing operation and providing digital infrastructure. For example, the counselors, trained counselors, and provide access to care, but supervised by the government, like the Ministry of Public Health, who supervise this, and you can gain trust from the people. This is what we have experienced in our country in Thailand.
Fascinating. Yes, next question. I see Ben
Sorry,
has the
I just
mic.
wanted to quickly, there was a moment there I noticed in Dr. Nup's slides, 52,000 users looking at various topics in health, and then 2,500 consultations, 2,500 consultations. I'm doing the math on that real quick. That's a 5% conversion. So it's a good idea, just keep that conversion in mind. To Yasmin's point, it's a challenging environment, definitely, to convert your digital audience to footfall at clinic, to footfall at pharmacy. You're going to see conversions that are on that order of magnitude, about a 5% conversion. So I think it's an important, I'm glad you had the brave enough to put that number up there. Thank you for sharing that.
So actually, we plan for 1 million followers.
Yes,
Thank
please.
Rihanna Ahmed here from Pakistan. Just about every NGO has a call center. Just about every NGO has a call center. I repeated that. How successful is it? Now that's the second question, and that we look at. And we find that it really is financially an expensive proposition. You need the training, you need the 24-hour service round the clock. And when a donor funds it, in our case it was FCDO, and when funds get, dry up, then what happens next? So I think these solutions are excellent and they are much needed, but it would also be important that NGOs amalgamate the call centers so that the platforms available for service are common. And, you don't just keep flouting your own brand. And that's where the government comes in. And the government then has to take charge and have that so that you're serving a larger number of people. These are experiments and these are very expensive, much needed, definitely required. But I think this fragmentation has to come to some kind of closure. That's my recommendation. Thank you.
Thank you so much. Would you like to respond to that? Or should
Yes,
Yeah,
I agree.
go for
Short answer. If you're a woman in many of these countries, where do I go if there are so many competing numbers? And I agree. If you're in the UK, for example, you can ring a number that you know. Yeah, you can ring a government-led contact centre, and that would be your safe advice for anything and everything, from a burn, a scald, to I need to talk to somebody who then will refer you on to where you need to go. We, as a sector, have tried lots of different experiments, and I think actually it is a really pertinent time to think about what is the cost structure of providing access to a service in a country. I would look to a government to help bridge that conversation. And secondly, then, what are the solutions, the digital solutions that would enable? I thought, for example, SwipeRx, I thought seriously excellent. Immediately, I thought to myself, can we do this with SwipeRx in Vietnam? I didn't think I need to develop my own, because there's already a solution out there. And I think that kind of mindset about playing to strengths is actually something that I would actively endorse. And it's something that is really close to our heart. So we like to partner with folks that can do things that we don't do, because they do it better, because that's their business model. And that's the way that we like to think about provision. So I totally endorse what you say, and I think maybe it's a good time for a conversation in certain countries.
This is an excellent conversation, and I wish we could continue. We do need to thank you and move to the other two speakers on this panel. Thank you so much. So I'll start with Vaibhav from PATH India. And these two presentations are really going to get into the specifics of policies and regulations in this space. So we'll start with Vaibhav and then move to Nene.
We are running late a bit. Auditor, yeah. Thank you. So I'll be talking about a high-level policy analysis we did across 5 countries, and I'd like to impress upon the commonalities and the differences between the countries, and focus on the larger themes. So this was basically a secondary review as well as some stakeholder consultations looking at the policy landscape and regulatory landscape around 3 main channels that I'll describe on the next slide. So these are the 3 specific things that we looked at: drug shops and pharmacies, direct-to-consumer channels, and the digital counseling aspect of it. So, and direct-to-consumer channels included the apps, the e-commerce, and the door-to-door services to the clients. So, and we need to know that all these 3 have digital components. So they are not, very watertight services. They can coexist. So looking at high-level analysis across DTC channels, because we are focusing on digital. So drug shop and pharmacies, we directly move towards the digital channels. We saw that there is little high-level guidance across countries on regulations related to direct-to-consumer channels, and weak regulatory advice on that. COVID expansion led to a lot of new innovations on this aspect, but government hasn't caught up with this thing. Especially in Kenya, Nigeria, we saw a lot of things come up. So with expansion there is a risk of quality issues, but however, regulations around quality can hinder people's expansion of these channels. Some examples from Nigeria. So we see there is a growth of e-commerce, but policy work remains to be developed around this context. And there is no strict regulation, but they do align around essential medical list in these contexts. Infrastructure is a common barrier. It needs to be strengthened so that last mile delivery, especially rural areas, because they focus on the urban context in this thing. And definitely self-care momentum. A lot of these tools are self-care tools, and COVID-19 pandemic has given acceleration to uptake of these services. If we look at digital counseling, again, there is a significant take-up in many countries, especially when we see in India. There is a lot of platforms that have come up, and however, it hasn't translated into specific policies for family planning. So after we conducted this, there was a national digital health mission launched in India, which focused on high-level policy guidance on that, but it doesn't specifically talk about family planning services. Coming to a specific case of India, So again, similar findings, but in some cases, the existing policies prohibit the online consultations. For example, prescribing contraceptives on over the phone is not very encouraged or is not allowed in India. So it can be prohibitive factors, as well as evidence generation. So when we spoke to some of the policymaker and government stakeholders, they said we need more evidence that it can be ensured with a quality, confidentiality, data systems, everything can be taken care of when we institute those systems. And finally, so looking at what are the key takeaways. So there is demand for some seamless, low-touch, quality AP options, and there is an opportunity in e-commerce and digital counseling space, but few countries have come up with comprehensive policies, and we have to distinguish SRH or family planning services from other telemedicine platforms, because there the doctor is a decision maker. Here we want people to decide for themselves, and this is a very big paradigm shift. We want people to decide on these platforms where they have to take informed choices. So the infrastructure as well as the training of the people needs to be very, very different in terms of helping people make their choices and enabling ecosystem to make that choices, including issues of privacy and confidentiality. Finally, again, e-commerce, people are happy that they don't have to step into a clinic, preserve their privacy, confidentiality when accessing or taking the services, but some of them do have hesitancy over when it is delivered. So the e-commerce platform has to be mature enough to make sure that it is the privacy and confidentiality of that service is maintained. So I'll pause here and we'll take questions.
Hello, bonsoir à tous. Ma présentation sera en français ce soir. Ah, see? Oh, someone's, okay, thank you for cheering up there. So yeah, no, seriously, we need to have more French sessions. Sorry, I had to say that. So like other people have said before, we looked at 3 countries and looked at what is going on in the landscape in terms of digital health, in terms of FP, family planning services, and including telecounseling in these countries. So it was Côte d'Ivoire, Burkina Faso, and Senegal. And this work was done by Salient Advisory and commanded by the Gates Foundation. We talked to 40 key informants across different sectors. Oh, I don't have the key informant list, but we talked to innovators. We talked to decision makers, to policymakers. We talked to pharmacists, and we also talked to NGOs and other people involved in service delivery. So what we found, and I think it's pretty similar to what other people have said throughout the afternoon today, there's a need for government regulations, right? There's a need for regulations. And most of the government and the regulators we've talked to were just like, where do we start? How do we start? Those are the main questions they had. It was not, we don't want this. It was more, how do you make this happen? The other thing is that they've talked about a potential pilot. And I think, again, someone else talked about that earlier. We want to start, but we want to pilot this. We want to make sure that we take into account certain safety measures. We want to make sure that it fits within our overall policies. So there's a lot of discussion around that, but there was no, restriction or clear barrier on their part. So one of the key things that was said in one of the countries was that donors can help us not only with funds, with expertise. So definitely there's, again, trying to see what has been done elsewhere and learning from that. I'm sorry, this is a little bit dark. I'm not sure you will be able to see this. But we went through the different barriers and tried to organize them per area. So we've seen from the SRH code, in a lot of countries there is a SRH or a public health code that exists. And that code is not conducive so far of telemedicine or e-health or digital health. The advertising codes, in most of the Francophone, we inherit from the great French legacy in our countries. So in most of the Francophone settings, you cannot advertise for medication on TV. And, advertising online fall into that category. The other thing is around the general regulation of pharmacies. So technically, to set up a shop, to set up a pharmacy, it's regulated by location, by size, by the type of services you offer. So it's not something that is open and liberal, and you cannot just jump in and do this. So there are regulations to take into account. There's a code of pharmacy practice as well, that, and I think other people have alluded to that when they talked about education of providers. So people have to know how to run that, so there will be an education component. Data protection, someone else had a question about that. Again, compliance with laws. So a lot of our countries, at least for Francophone West Africa, are kind of coming up with the innovation, trying to understand what is happening. And, data regulation, ownership of data is still a fairly new concept. There are laws in some places, other places don't have laws. But again, those will be a set of things to take into account when you think about launching a digital initiative. So what we've seen is that the regulatory framework is not set up yet to really accompany that effort, so there will need to have some sort of reforms. We need to have some sort of harmonized approach if we want to make sure that this is successful and can be pushed up to scale. We need to enable online distribution, but taking into account the constraints that were shared earlier. So basically, like as a quick summary of what we've seen in terms of current framework. So in Côte d'Ivoire, Burkina Faso, and Senegal, there is an attempt there at a strategy, or there's some sort of strategy that exists in the three countries. It might be called in some instance e-health strategy, in other instance telemedicine, but it's somewhat get to it. The telemedicine regulation, so in Côte d'Ivoire we've seen that there was something established in 2018, but again, it's all about fixed centers offering telemedicine. It's not really online, fully digital. In Burkina and Senegal, there's no, it's unclear if it's clearly mentioned or regulated. And especially in Senegal, Senegal is working on a law. So technically, we are at the end of 2022, but before the end of 2022, we should have a new law coming out of Senegal that might help frame this. Digital counseling overall had no existing or no planned regulation. So it was just something that kind of existed. The regulators knew about this, but it was unclear what they would want to do or should be done around this. So there's technically less barrier to digital counseling compared to the other services and products delivery via online. In summary, our study found that the regulations right now are restrictive. If you just want to come in and open up an e-pharmacy or any kind of digital health shop, it will be hard for you to operate in the Francophone environment, especially in the three countries we've looked at. However, we know that some stakeholders, or at least several stakeholders, are interested in buying, interested in doing this. So there's, an element of looking at the potential and being able to offer solutions. Private pharmacies are individually owned in most of Francophone Africa, so you don't have a large brand owning, it's really individual shops. So thinking about key actors to engage, you'll have to work with the Ordre des Pharmaciens. So this is where we stop on with the study. The interesting thing about this scoping and this insight was that Salient Advisory was able to pitch this to the foundation, and the foundation is interested in having a multi-phased program that is going to cover 13 countries in Eastern and Western Africa. And the idea is to convene all those regulators, because again, everybody before us talked about the lack of convening and information around this. There will be an attempt to create a regulatory learning group, and we hope that from that learning group will emerge policies that will support this environment, and will provide resourcing to support the regulatory framework. I'm going to stop here. And right before I stop, I have a quick question. How many people here are pharmacists or working in a pharmacy or have a pharmacy degree? 2, 3, 4. So again, we want to engage a sector. We all talk about how they are missing to the conversation, but they are not here. So, first thing we have to do, maybe. Merci beaucoup.
Thank you. I want to make sure we have enough time for your questions. So I do have my starter question, but let me also just open it up to see, is anybody ready to ask a question? Yes, go ahead.
I hope people can hear me at the back. So, excellent case for bringing in the regulatory authorities to provide that policy support structure for making this happen. But I think it's not just about pharmacies or linking consumers with distributors. We are talking about sex, we are talking about contraceptives, and we are talking about young people who are sexually active. And these aren't governments that are rights-based for the most part. The only reason why we've been able to operate this way for the last several decades is because the government hasn't stopped us from doing that. The minute we engage the government, we run the risk of, what? Prohibitions across the board for how we can talk to young people. Right now, they're not aware this is happening in the digital space. So the question is, what's your recommendation for treading this space delicately in a manner which protects the rights-based agenda while working in the digital regulatory space? Oh, sorry. My name is Zahir Gul. I'm with the Frontier Health Markets Engage project and from Pathfinder International.
Thank you. This is more of a contribution. Unlike what you mentioned, behind closed door, maybe you're right, because we met few stakeholders from Francophone Africa, and in private meetings, what they said was, help us. We know young people, they're active, having sex. We don't see them in the facilities, so we want to really push for digital counseling so that they have a reliable source for information where they can even be referred to get methods. So I totally agree with you, but also undercover, they need help. And because these young people are not going to the facilities, and they are feeling more and more the pressure of their UHC, FP2030, ICPD commitment. So that pressure is there. I think the time is ripe. Let's kind of navigate, and again, policy is needed, and they either close their eyes and let us move forward to avail information, but let's find creative ways. Thank you.
Thank you. My name is Natasha from Kasha. My question is, maybe we also align with what they said, do we really need new policies on digital health, or do we need current policy to acknowledge digital health? Because I'll give you an example of in Rwanda, where we did, the government was working on DMPAC introduction and scale up. So what we did is we pitched to just add digital health as a channel, but no details. So I think maybe that's where we need to go. So I don't know from the panelists if you think that would be maybe a start. Thank you.
Yes.
It's on.
Hello. Yeah. So I think a quick reply to this would be, we just, the regulatory or policy response may not necessarily be government controlling this thing. Government can come in and help them self-regulate. So all these platforms can come together. There are many industries who self-regulate. So they set up their own standards, so that there is government helping them to form that policy, but doesn't have complete, say on what you can and can't do. The industry decides for itself, coming to those standards. So we want government to give a broad policy framework. Within that, there is enough space for rights-based approach. That would be a quick reply.
Thank you. And again, I think the spark in the discussion tells how important this is, and how importantly we need to have these discussions, not only at country level, but also at the regional level, because some of these policies doesn't apply only to one country. It could be looked at from a regional perspective. But one thing I'm going to say, if we are all thinking about sustainable and long-term visibility on this sector, we want to carry it long-term, we will need some sort of regulations. And again, with my co-panelist here, regulation doesn't mean control. It will mean different things in different places. But I agree with you that we have to be cognizant, especially from the vulnerable population we're trying to meet, because when we start regulating, sometimes those populations get excluded. But I guess that's the role of all the activists and NGOs that are in this sector, to make sure that when the regulations are discussed, they are at the table to talk about the marginalized and the vulnerable.
And just to quickly add, when we spoke to some of the providers, they also want guidance on can they sell it to minors, below 18 people. So there is no clear policy guidance. So even if there is a high-level policy guidance, that will help them to explore that population and attend to that market.
Yes, go ahead.
I think that's exactly guidance is where actually you can operate to enable access for young people. Because as soon as there's guidance, it could be that there will be many more restrictions and surveillance. And that's the point that you're making. Like in India, age of sexual consent is 18. So even if you're trying to procure a commodity and service, there may be questions around your legal age. And it can be judgmental, it will be stigmatizing, and it can also be no access. There could be any ways in which, and as soon as you put regulation and guidance, it actually takes away that gray space in which you're operating. So I think it is a challenging question. I don't know whether regulations are the way to go or we need something else plus regulation.
Yeah, go ahead.
No, I think, we as a sector wants to protect and make sure that we provide access, but let's think about the long-term vision. Let's think about all the innovation that we are inhibiting because of the gray area. So depending on what part of the world, depending on where you are, you will see different things happening. So in Francophone setting, for example, the lack of clarity stop you from innovating. So everybody, for example, in Côte d'Ivoire or Senegal that has tried to open on online model like what we've seen in other places has been harassed and shut down by the government. So we need to think about it in a different context. We'll have different roles, and that's why we talk about regulations and not necessarily laws. But yeah.
We have a hand in the very back. Thank you.
I think it's on.
Okay, thank you so much. I'm Celestin Compaoré. I work from Jepaigo. I'm a regional project director for GMPSC. My question is that after this pilot analysis, did you share the report with the government, with the recommendation? Did you develop the action plan for them? And the next step, what is the situation after the report, if you have started the discussion with them or not? Another thing is to know, when we do the pilot, can you share more the result of this pilot? Probably this result can help to mobilize another country to engage for this new situation. Thank you so much.
So regarding the Ouagadougou partnership or French-speaking countries, the 3 countries we've talked about here, I think I mentioned it that the foundation, the Gates Foundation, was kind enough to provide a grant to Salient Advisory to work on a larger scope approach where the regulators, the innovators are going to be in the same space and help decide on some of the regulations that needs to be put in place. In terms of that's the immediate next step. And from that step, we'll hopefully generate a pilot and see, how do we pilot this? What does it need to look like? So the pilot is not the first answer. It's having people convene into some sort of a marketplace and discuss what needs to happen, both in terms of regulations and in terms of actual implementation. And of course, yes, the government, in a lot of places, government participated in the study, and yes, the report was shared with them.
Thank you. We are actually at time for we want to make sure that there's enough time for the last panel as well. But I want to thank the panelists and also highlight the complexity of the role of the government in this space, which I think you've really underscored here. Nene mentioned that many governments want guidance and expertise to support their decision-making around policies and partnerships. And as an FP community, I think we can shine a spotlight on the need to do away with unnecessary restrictions, such as on over-the-phone prescriptions or online sales, put in place more clarity around what is authorized, and protect consumers. So for example, data security requirements came up strongly. And then through public-private partnerships, like the one that Dr. Anap described, we see how the government can help clients navigate this vast landscape of online innovation to find the high-quality services that clients can trust. Thank you all very much, and I'll turn it back to Doreen.
Thank you so much. Normally, we would spend another 5 minutes of break, but we are so delayed. We are going to continue. No break? Okay. Wonderful. Everyone agrees. So we are going to quickly continue with the third panel. And I think these are at the core of the discussions that are happening right now. So this is great. And for that, I'm going to invite Lester, who is going to moderate the third panel. Lester is DKT's Director of Innovation and Learning and has championed sexual and reproductive health and human rights issues throughout his career. So it will be great to hear from him and from the panel. And I know this is going to be more interesting. So welcome, Lester.
No pressure at all. Stay away. So I'm not going to come too long between a very exciting panel and setting up this conversation. It's strange that we didn't hear the word pleasure at all till now. You got an excuse, Ben. You haven't heard the word orgasm in this conversation. You haven't heard the conversation speak directly to the violation of the dignity of the human person that happens in the digital space, whether it's in the metaverse, whether it is on any other digital platform. This panel is going to bring out some of those issues which sometimes get spoken of in shades of gray, but never in black and white. And today the attempt is to have that conversation more openly, because unless this community recognizes that sexual and reproductive health and rights is anchored in much more than contraception and safe abortion. It is anchored in the principle of freedoms that every individual must enjoy. The freedom to choose whom they will have sex with, the freedom to decide what is pleasurable to them, the freedom to decide whether or not they can challenge their state about its policies. And yet, the conversation till now has been about what we are doing for women. The Bruce and Jane framework on quality of care, Ben, how many years ago that is, 40 years? Still is the pivot of measuring informed choice in an age when how agency is experienced is very different than a provider giving you information. In an age when how the violation of that agency happens is happening without a provider of who is taking down whose ads on Metaverse, who is taking down whose content is not transparent to Ben or to any other digital platform provider. And that is a violation of a right to information that women are seeking. So these are some of the questions that this panel is going to explore. We don't believe there are answers, but we believe that we must begin the search for how to answer those questions, what kinds of evidence are going to be required, what kinds of capabilities are going to be built in the future workforce of governments if the digital is to be realized as one in which governments are owners and participants in in these platforms. So with that, I'm going to start with Anne Philpott to wake you up. Anne, as many of you know, Anne worked at DFID. When she left, they renamed it to FCDO for some reason. She's going back there someday, she tells me. we'll get used to calling it DFID again. And over to you.
Put me on first to wake everybody up, goodness.
Let them start with pleasure.
Are you really the first one to have mentioned pleasure in this session so far? That's about to change. I hope my slides are going to come up. Oh, okay. Oh, it's all organised like this. Ah, okay. I think the order's been rejigged, so that's Esther's. Yeah, if you go forward. There we go. Okay. Now we're talking pleasure. So I'm from the Pleasure Project, and we are on a mission to bust the silence around and the stigma around discussing pleasure in the sexual and reproductive health world and build bridges between the world of pleasure and the world of public health. So we see ourselves as the guerrilla girls in SRHR. And, you know, one of the things we do is get everybody to think, and you can look at this question and think, when were you last asked this question? When did you last think about this? When did you think about the best experiences you've had in your sex lives? Because it's like a muscle that's diminished through our lives and through our sex education, and some of us more than others, where we're kind of silenced and shamed to think about what we enjoy about sex and sexuality. And as I say, how can we know what we want when all we're ever taught and told to do is to stop things? And so it's also a key component of sexuality and one of the fundamental reasons around the world people have sex and seek information, in fact. So what we do is we ask people this question. I'm going to talk about some evidence work that we've done with WHO, but we also work in partnership with many organisations to integrate pleasure within their interventions. So, and a key, I think I can just click, right? And a key reason or a key attribute of contraception, which is one of the scenarios that people have pleasurable sex, is that it allows you to have sex without that fear of unintended pregnancy. It allows you to feel more free. And I guess, you know, I want you all to think to yourself as well, how many times in your life or in your lifetime will you have sex for reproduction? Out of all the other reasons you've had sex. And, you know, some of them might be up there. And just to sort of highlight that this is the first ICFP that's had a formal track on pleasure. We've been shouting on the sidelines about the importance of pleasure for many, many years, but this is the first time there's been a formal track on pleasure. But there's still less than 1% of content at this conference which is focused on pleasure. And I'll tell you about, there's 2 panels, but I'll tell you about them at the end. So just to, you know, also really lift the bar in terms of what we discuss in the sexual and reproductive health world, and lift the bar on our aspirations when we're talking to people that use our services, that use our apps, that it's not just about stopping death, danger and disease, it's also about, you know, building on sexual rights and empowering people with the agency to think about what they want in terms of their sex lives. And so I think also everything that people have been talking about in these in the panels beforehand, of course it's absolutely essential to talk about safe sex and to talk about stopping sexual violence. But then what? What are our aims for the people that we're serving? What are our aims in terms of what we want them to achieve? What is our aim about gender equality? Let's lift the bar away from thinking about less painful sex or sex that might cause an unintended pregnancy and say what is going to be enabled with that. And of course, contraception's really important in terms of, you know, economic empowerment, in terms of education, but also what else does it enable? What are the motivations that people might use it? On the next slide, I'm just going to talk about a really critical piece of research that was published in February this year. It's been a long time coming, about 3 years, and we've done it with support from the Case for Her and with the World Health Organization. And it's a systematic review of the evidence of what difference it makes to include pleasure in your interventions. And for, some of you might know what systematic reviews are, but it's a gold standard way of looking across all of the research that may help you answer this key question. And the question is, what's the added value of incorporating pleasure in sexual health interventions? And we launched this on Valentine's Day, very appropriately this year, and it got a huge amount of interest. The results were really striking. So we looked at all of the experimental research over the last 15 years that hoped to have an impact on sexual health. So that's anything that compares one intervention with another intervention. And we found 33 studies that had included pleasure and compared that to the same intervention that didn't include pleasure. So that's not very many studies, but it's a good start. We looked at about 13,000 abstracts. And we found, and we did a meta-analysis as well, is when you're able to pool the results against one outcome, which was condom use. And we found a significant positive impact on sexual health outcomes when pleasure was included. And that included condom use, and that included other outcomes. So this is really important now in terms of a key effective intervention for us. So this is not something, often people think, oh, pleasure, that's fun, or that's a bit frivolous, or that's great, Anne, but that'll make it more exciting. But it's actually a really important, effective part of our toolbox in terms of interventions. And if it was something like, I don't know, a new technology or a statistic around a microbicide, then people would be saying, wow, we really need to use this. We need to put this in our toolbox. But I think what's also really important is that it doesn't require a whole new health system setup or a new technology delivery system. It's not expensive. It's about changing the conversation. It's about flipping the narrative. And for those of us delivering sexual and reproductive health services, thinking, how do I think positively? How do I, build on my conversation to imagine that people have sex for a potential positive outcome? That they might be wanting to have a fulfilling relationship, they may be wanting to have pleasure, and actually just changing that narrative, and to stop gatekeeping ourselves, and to stop only answering questions with what you should stop doing or what the risks might be. And in those interventions that did that, there was a significant positive impact. And I know some of you have talked about how that brings maybe more people to your service, or in the abstract that I wrote for this session, I've put 3 examples of digital health interventions that were more pleasure focused. So one with IPPF Africa region, one with PSI, and one called Ana Autoestima in Brazil. And they all found, and they did A/B testing, they all found that pleasure conversations brought a lot more people to their content and brought a lot more positive engagement. And they then went with that pleasure content. So it's about changing the content that you have to bring people to be able to also know that it's an honest, holistic conversation. And one thing we've seen again and again, and we've seen in research, is that particularly young people say that they trust content if it's that holistic content that also talks about what they want in their relationships. And one teacher in Ghana summed it up very nicely in a piece of research we did, where he said that he would talk about pleasure but also risks in his in the sex education he did, because he said, if you tell young people that sugar tastes horrible, that it's bad for you, then one day they're going to put their finger in the sugar pot and taste it, and they won't believe everything else you've told them. So I think it's also about that really recognizing that it's a key motivator for sexual behavior. Okay, I'll speed up, but just to say this is open access. Please find it on our website. I've got 1 minute. I'm going fast. And then just on the next slide, that's just an infographic showing the research in a more easy to understand way, because with moving to the right-hand corner. Anyway, I'll be quick. I've had a lot of coffee, by the way, because I flew in yesterday, so please, I'm probably going too fast. This is what we call the pleasure principles. The Pleasure Project designed these based on the research we did with WHO, but also the World Association of Sexual Health, Sexual Pleasure Declaration, which some of you may have heard of, which is the first global normative agency to put out a call to action around sexual pleasure that's rights-based. They were also the first agency to put out the Sexual Rights Declaration, so, which is now, very universal for all of us. I won't go into these in detail, find them on our website, but basically it translates the evidence and best practice into really inspirational, easy to follow steps on how to implement pleasure-based sexual health, with lots of links and examples. Critically, it's about flipping the narrative to be positive. It's also about putting rights first. We can't have pleasure-based sexual health unless they're rights-based. But it's also about many steps on the journey, including my favourite, you shouldn't have a favourite, but about loving yourself. So recognising your own journey and how you may have had sex education which shamed you in the past or was negative, and recognising that it's important as a provider to also ask yourself the question, are you pro-pleasure? Now you know that this is also a very effective intervention. And then just lastly, we have a pleasure hunt at ICFP. So look out for our pleasure resources. Come to our session on Wednesday to find out more.
Any two questions to make this conversation move forward? Anyone, any questions to Anne at this point?
Yeah, can I ask?
Sure, go ahead. No, you can speak to the mic. Where's the mic?
You can come up here.
Okay, yeah.
Okay. I think as you were talking about pleasure, as you said that this is the first time we talk about that, I kept thinking about our context, and I was wondering how you talk about it to young girls and women in our African context, because I think that's not how we are educated, let me just put it like that. And secondly, as you introduce this new concept and principles, what are the barriers that you are facing in the community, in the place that where you are working? So I think those were my direct questions.
Before you respond, let's take a second question.
I have to remember them.
Anyone else?
I want to know, Anne, I love the fact that you did the evidence review. That's really useful. But I want to know which governments are much more open and receptive to take on the ideas around the Pleasure Project and principles in their policies, and what might characterize that openness.
And 2 minutes to answer.
Sure, and come on Wednesday to our session, Navigating the Pleasure Gap, because we're presenting with WHO, IPPF Africa Region, and Amplify Change, and a project called Young and Alive in Tanzania that's pleasure inclusive. So there'll be lots more examples on Wednesday, but just to say, we did some research in Ghana and Kenya to look at, with young people that we trained as researchers, to look at positive examples of, in a whole range of different ways, about pleasure inclusive sex education. And we have that on our website. So that has lots of examples about how to navigate and how to include various levels of content that's pleasure or well-being focused. And also our partnership with the Africa region in IPPF, which is the first pleasure-based sexual health program that IPPF has done at that scale, is with the Africa region drove that. It's called Treasure Your Pleasure. That's in a whole range of countries in Africa region. And we'll have more information about that on Wednesday. They found that they had a significant upswing in young people going to their clinics during those few months of the campaign. So I think it's also about the fact that recognising that that's where young people are going for their content, and who are the gatekeepers to that type of information. And also as part of that IPPF campaign, they did a whole piece of research called Heritages of Pleasure. So we worked with social media influencers in the African region, and one of them was about pre-colonial narratives of pleasure in the Africa region. So it's also about recognising what's happened in terms of what might be those heritages of pleasure around community information, around discussions that's been silenced by patriarchy or, more recent historical narratives. And then the second question was about governments. So we have a partnership with Amplified Change, and for those of you who know, it's a fund. They've just changed their funding guidelines to include pleasure as one of their commitments to the pleasure principles. So organisations can endorse the pleasure principles, and I'd love you all to come and talk to me about that afterwards. And there has been some discussions with governments that have wanted to expand the work with the Amplified Change grantees, such as in Lesotho, or it's not a government, but some national federation in India, the National Federation of Sex Workers as well. So I'm rushing because there's a lot of examples of some of... Yeah, sure.
Yeah. Thanks, Anne. Thanks for time.
I hope I woke you up.
So I'm going to invite... You need the mic? Okay.
It's on the table.
I thought I could project. Okay, thanks. So I'm going to invite Esther Kismodi to come up next. Esther? Okay. So Esther is the editor of RHM. But more than that, she's been someone who has spent her career anchored in human rights on a range of issues, particularly sexual and reproductive health, and most recently has begun work on understanding the linkages between human rights, technology, and society, and is working on a volume of articles that will happen sometime in the near future that will explore these debates and discussions in depth. So Esther, with that, over to you.
Thank you so much, and good evening, bonsoir. So I'm trying to make rights sexy after Anne, although it might be not so pleasurable for some. And I'm trying to get back to many of the points that were raised in this afternoon. I don't see with this. And really try to bring it together, what we talked about from a rights-based perspective. So starting with this, with some summary, it's the evolution of the digital technology, and you talked about mobile apps, the internet, telemedicine, digitalization of health systems, artificial intelligence have rapidly transformed elements of sexual and reproductive health care. While these technologies, as many of you pointed out, have been often developed with the intention of broadening efficiency and cost effectiveness, and very often addressing marginalized populations and inequalities, increasingly available data shows that rushing to embrace digital technologies can risk undermining human rights, such as right to non-discrimination, right to privacy, right to dignity, and health and human rights principles of accountability, transparency, and participation. As the UN Special Rapporteur on Extreme Poverty and Human Rights cautioned in 2019, digital technologies could be a Trojan horse for forces that seek to dismantle and privatize economic, social, and cultural rights, undermining progress towards the SDGs instead of speeding social rights. So what do we mean by that? And I think it's a point of time when we need to breathe and come back what we learned about health and human rights in the past 30 years. And let me come back to the very basics. We need to ask, in relation to digital technology, sexual and reproductive health and rights, and the private sector here today, who are the rights holders and who the duty bearers are. Starting with the duty bearers, and I would like to clarify some concepts from the rights perspective. The primary responsibility for respecting, protecting, and fulfilling human rights is the state. The state includes the government, the Ministry of Health, the Ministry of Justice, the Ministry of Technology, the Ministry of Women, as well as parliamentarians who develop legislation, both on preventing surveillance and protecting privacy and dignity and non-discrimination, as well as the judiciary, who provide remedies and redress if violation occurs. We also have other actors, like the private sector, who has the duty to implement and protect human rights. Eventually, it's the responsibility of the state to monitor the private sector, and the private sector needs to monitor the state, how these accountability mechanisms work. Let me stop for 1 minute also about the private sector. Today, we talk about private sector from many different perspectives, and I would like to clarify that private sector exists in relation to digital and SRHR, at least from 2 perspectives. One, the private sector who is involved in the provision of sexual and reproductive health services, such as the pharmaceuticals, such as the business sector, such as private hospitals and manufacturers and distributors. And there is a private sector who is involved in the development of technology, and very often they don't care or think about sexual and reproductive health and rights. In some instances, the two overlaps, but sometimes it's completely different. So we need to think about the private sector from both perspectives. While both types of private actors can contribute to positive sexual and reproductive health outcomes, they can also jeopardize it, even unintentionally. Without carefully assessing the intersectional nature, and in addition to pleasure, I would like to put out these buzzwords: power imbalances and structures, the nature of privilege, patriarchy, and colonization, both globally and locally, the use of digital technology can deepen exclusion and discrimination. Let me give you 3 very specific examples because it may sound very theoretical. One, the failure to investigate and address the complexity of digital gender divide raises the question of health and human rights accountability of both public and private actors. What does it really mean? Just a couple of examples. Data from Uganda shows that men participated twice as often as women in the SMS text message-based campaign on HIV prevention. In the Democratic Republic of Congo, over 80% of callers of family planning hotline were male. In Ghana, 2.5 million out of the 31 million population, fewer women have online. 2.5 million fewer women have online access to information than men. So let's stay with this Ghana data. Not taking into consideration structural factors of inequalities, including that 2 in 10 girls married as children, and the majority of adolescent and young girls live either under parental or husband control, will not only lead to the failure of digital programs aiming to address women and girls, but can further deepen gender inequalities. It will be 3. The second is the misuse of digital data. We talked about menstruational apps and fertility apps. There is increasing documentation that private data bought up from these apps and used by anti-abortion campaigners not only provide misinformation targeted to persons, but also harass individually people who are going to the abortion clinics. Marginalized communities, people living with HIV, sex workers, LGBTI communities in criminal settings are especially in danger. Their data that is often collected by the health sector is misused by the government for harassing and prosecuting these people. And one more point on this one, that the concerns are not only from the individual perspectives as rights concerns, but also the health system perspectives. Take, for example, maternal death reviews. These are very carefully implemented systems, but introducing the digital in these systems and expecting community health workers, for example, to report within 24 or 70 hours in the digital, and otherwise, like in Nigeria, they face criminal penalties can jeopardize the whole system without training and education. So as a conclusion, exactly, developing human rights impact assessment. I would love you to repeat. Human rights, don't repeat, but human rights impact assessment is very important in relation before introducing any new sexual and reproductive health digital technologies. We don't know what is this, so let's learn and develop them together. We also need to introduce continuous monitoring of digital that is not for sexual and reproductive health purposes. Self-regulation of individual private companies cannot be sufficient enough because it's often contradictory of self-interest on business and profit. As well as talking about just regulations that developed by the government is not enough. We need to educate the parliamentarians and the judges and others how to do it. And bringing, so if the buzzword is developing regulations and laws, please let's be careful to bring, for example, EU regulations to Africa and Asia and all over the world, because they exist in a very particular social, cultural, political, legal context. This needs to be individualized and contextualized. We need to do a lot, but we have to do it right now. Thank you so much.
Esther, just take two questions very quickly before we... Ben, go ahead. Yeah, you can take this mic.
Esther, first apologies. In the first panel, you had questions for us about the human rights, and I said, wait to the third panel. I didn't realize you were the third panel, so my apologies. So, with that in mind, it was great to hear about examples where things have fallen short. And it's, in some ways, I feel perhaps easy to do that. We see when things break. I'm wondering, do you have examples of metrics to quantitatively assess when something has succeeded? And I'll give you one example. The Method Information Index, the MII, is a standard research-based index to measure the level of informed choice in individual patients leaving family planning counseling sessions. Now, those can be implemented into digital counseling apps and ask the participant, the client, after leaving, was she or he effectively counseled? And so you could, in fact, begin tracking the degree to which an app helps an individual be more informed prior to going into that digital setting. So do you have other examples of metrics that we could use in rights-based settings to build up?
I think you are talking about two things. One, yeah, I mean, I think one, that how the consumers can monitor the implementation of human rights. On the other hand, I think this kind of metrics can exist that we can use to measure accountability of the different actors. And this work is just happening. And this Human Rights Impact Assessment Index is being developed right now. There is a special edition of the Health and Human Rights, International Health and Human Rights Journal. And there is a matrix about it, what kind of questions we can ask to monitor the implementation of rights. I don't want to be diplomatic, but I need to be short and would be happy to discuss further because there is great work is happening.
Okay, a second quick question. Yes. Somebody at the back there? Yes. Go ahead. Yeah. Mike?
Hi. Sarah Cotty. I'm the founder of IMI. We created a watch that tracks your menstrual cycle without an app. So I was resonating with both of your comments, both the data privacy aspect of this and also kind of disruptive products. And my question mostly to Anne is around a lot of the feedback that we've seen.
It's okay. It's okay. No.
Oh, sorry.
It's okay.
Sorry.
It's okay. It's totally okay. It's totally okay.
I mean, you can answer if you want as well.
Go ahead.
So in our pilots, we're doing pilots with UNFPA at the moment, and a lot of the feedback that we've seen is that girls are loving the watch because of the fashion. And this is, again, kind of like it's normalizing it and it's making it interesting to them, and this is such a big part of why they're using this. However, when I focus on fashion, it's seen as frivolous. And I feel like maybe it's similar with the pleasure aspect. It's kind of seen as like somehow on the sidelines and not important, but as you said, it's the reason that most people have sex most of the time. So how do you think we kind of like bring this whole conversation back down to earth, and it's okay that these type of things are actually the things that are driving participation and growth in knowledge?
Should I just do it now?
Yeah, go ahead.
Should I take this one?
Yeah.
Is that working?
No, this one.
Oh, okay. I think we're going to have a panel as well, so there'll be some chance to talk later. But just, I'd say I absolutely agree with you. And I think particularly if we're thinking about the private sector, there's a huge amount of history of the private sector using positive motivations to, build brands, to sell products. So if you think about it, when we, see toothpaste adverts, we don't see pictures of people with like decaying mouths. We see pictures of people looking sexy, smiling, even washing up. Everything. I'm not saying that we should always do that, but, that's something which then is the positive motivation for change, which we also know in research around health behavior change. That's what works. It's about motivating, simply through pleasure and love and well-being and joy rather than fear. But we in the public health world have got very hooked on motivating through fear. And what you saw from the research that I presented, that's not working as effectively. And so whatever that positive motivation is in terms of, fashion, well-being, I think that's something that, it's been such a gap for our world. We've basically lost an effective intervention, and we've lost effective condom use. And what we've seen from our systematic review is that it increases condom use. It basically saves lives. And we in our community need to get over this stigma and this silence that we've held for so long in terms of gatekeeping it. I think the other thing that, what we've also been talking about is what brings people to apps and what brings them to online. And over the last 10, 15 years, now there's been an explosion in access to explicit media. And we continue to put our head in the sand in the public health world about the fact that people are going to look at explicit media and, frankly, largely harmful porn to get their sex education. And we need to catch up and provide responsible content online that's also pleasure inclusive, but that is rights-based, in order to recapture people that are learning from harmful explicit media online.
Thanks, Anne. We'll come back to more questions to the panelists. Next, I want to invite Vitika Yadav. Vitika comes from a background of having championed the rights of women and girls and the human dignity of all people, dedicated her career to working on behavior change through the media. But most recently, for the last few years, has been leading a bold and innovative organization based out of India called Love Matters, which gladly annoyed the government of India for a brief time. But Vitika is going to share their experiences with Love Matters and how they are navigating the digital space. But also, Vitika, do talk to us about the important issues around donors and the implications for platforms like yours, as donors chase a different metrics of success than what you seem to want to bring to our ecosystem.
Thank you, Lester. I don't have any slides to present, so also because I would like you all to have the pleasure of logging on and seeing what Love Matters is all about, and perhaps also take back some tips to use to have more pleasure in your lives. On that note, Love Matters is India's, I can safely say, world's leading digital initiative on sexual reproductive health and rights. In other words, we talk about love, sex, and relationships, and we talk to young people. We bring open, honest, pleasure-positive, friendly information to young people through digital pathways that they prefer. Now, we work at the intersection of media and public health, and we use websites, social media, also new media tools like augmented reality and virtual reality to have conversations with young people, but also other stakeholders in the ecosystem. talking of course, we've been talking a lot about technology and digital spaces, and I think an important reason to understand how digital and technology platforms operate is to also understand that technology can transform, sort of gender and social norms, but in many ways it also shapes, it is also shaped by, social norms and gender norms. So for most part, the attitude that one would see replicated in online platforms also not very different from what we see in the offline spaces, where a lot of groups feel marginalized, they feel discriminated, and there are lots of those things which are there. If we have had experiences of putting something online and how you might have been targeted with certain comments, it also grows to show that an important responsibility in terms of when we are designing digital solutions is also to understand how these platforms operate and what is by design, how to make them smart. And in that context, I think, in our journey of 10 years at Love Matters, we have had, it's been a learning graph for us. There is a lot that we have learned on the way. There's a lot that we have experimented. And we have sort of used that to not only learn, but also to share with others. And I'm very glad to say that a lot of programs are actually using Love Matters, have been inspired by Love Matters, and in many ways is contributing to the impact that other organizations are having. And I think often we don't talk about it. I think the biggest challenge is that when donors are looking at impact and what impact you have had, how do I tell them about this impact? How do I tell them about sort of the free service that we have been providing for past 10 years? How do you quantify inspiration? How do you do that? And at the same time, there is sort of a starvation cycle because we are constantly trying to prove what we are doing. And this question around sustainability and monetization, which I think is extremely important, but we also need to understand that nobody wants to pay for content. Please let us look at a lot of news websites and portals and see how their subscription-based model is actually working for organizations. And we are in the space where we are competing with the very popular pornographic websites, right? There is no other alternate space. So there are lots of challenges, and I think when thinking of donors, we look at outcomes, but I would like donors to actually really think about these questions. Where are we perhaps underinvesting? And while we are underinvesting, what kind of, sort of impact would this have long term? We are in the business of changing social norms, challenging social norms. And I think one of the greatest success when we're talking about proof points in success, I think the kind of conversations we have on platforms where people are also getting very upset and angry with us, even government or let's say the gatekeepers, even service providers, I think the important thing to understand is that this is success for us. People are upset because we are challenging something that they're uncomfortable with, right? So why not see that as success, as impact? That's an outcome. Unless we're going to have these bold conversations, things are not going to change. So I think it is also about putting it back there. And I think I also want to use this opportunity to make the point that I couldn't make for the previous panel, which sort of links to this, is around advocacy. Now, when we're thinking about policy and advocacy, we never want to think, we are always wanting to think about it from the perspective of providers and what we think, we can lobby with the government. Why can't we just listen to young people, work in the gray areas and let things change in the long term? Because when people are going to demand something and they will advocate for it themselves, things will change. Let us not just sort of, personally, I feel that we shouldn't get into, sort of making things much more complicated by adding more regulations. Gray zones are great. We have been operating in gray zones for a long time and it's wonderful. So let's just make use of that. Thank you.
Stay there for a minute and take any 2 questions from the audience or any. Yes, go ahead.
Not so much a question, but a comment. So just an observation that the pleasure part of this panel also came last. So it's also probably not intentional, but like a mental reflection of the whole state we are, as a conference that's focused on family planning, but still puts pleasure third, I guess. All right, thank you. So comments. Oh, by the way, my name is Morinike, and I'm the founder of Whisper Health. We're a health technology startup that is focused on increasing access to healthcare for women, especially sexual and reproductive healthcare. Thank you.
Thank you. Anyone, is somebody else who had their hand up here? Go ahead. You need the mic?
I wonder if you could share whether you feel that this kind of work could have happened effectively or as effectively as you think you're delivering prior to the Supreme Court decriminalizing sex in India or same-sex relationships. I wonder whether that has anything to do, or for countries where that's not yet happened, what you would recommend in adapting this approach. Because this overt, you made the government uncomfortable, but the law didn't crack down, did it? Or we don't know. Could you share something on that?
That's a very good question. One, we have been in India for 11 years now. And we actually expanded to Latin America, China, Africa, and Egypt. And we have, Love Matters is worldwide. We have been operating in these challenging zones, but again, making use of these gray areas. So that would be one tip that I would leave everyone with. And essentially at our end, to be very honest, we have been very strategic about how we want to engage with government, because we do not want to sanitize what we offer. So the advocacy that we engage in is really with people, and we support partners who are advocating directly with government, but we do not want to be in the limelight. In fact, there is a lot of work that we have supported of different organizations where our logo is also not. So you have to be comfortable with it. And again, because we're talking so much about partnerships and perhaps what we have to give to each other, one of the bigger challenges we have faced is, all right, Love Matters, 20 million plus audience and connecting to service delivery. Yes, we work with the medical students. We're trying to catch doctors early in their careers to be able to, sort of see what long-term change would we have to offer. At the same time, we feel that when people are coming to Love Matters, because there's so much trust, they almost want everything from us. We are not doctors, right? And we keep telling them, we keep referring them to providers, but they want everything from Love Matters. So I was just thinking, how hard is it to actually be able to use Love Matters as a brand and call some of the existing clinics Love Matters clinics, right? And perhaps think of models where we are not so invested in trying to create our own brands, but sort of a little bit more open. And I think that's the future, and that's where we need to sort of look at some of the restrictions that we ourselves face in this sector. And of course, there is competition. But more than that, I think we need to also learn to work with each other, but also have donors really see what is there to be offered. And in a space where we are, being censored all the time, there is another panel on the 16th called The Naked Truth. Sorry, very quickly, which is about online censorship, and you will see examples of the kind of content that has been censored, and we'll be talking about online gatekeepers, but then also the opportunity for donors to perhaps invest in metaverse, right? So that we are looking at some of those long-term solutions as well. Thank you.
Thanks a lot, Tika. It was great. Thank you. The fourth panelist with us is Manjula Narasimhan, who has spent a lifetime dedicated to both the research as well as the policy and normative guidance formulation in different roles, but particularly through WHO, to help the community both raise the right kinds of questions, but also evolve consensus and documents and policy guidance that helps the community move forward. Manjula?
So hi, everyone. Last speaker of the day, so thank you for that, Lester. Okay, so as Lester said, my name is Manjula Narasimhan. I work in the Department of Sexual and Reproductive Health and Research at WHO in Geneva. And this panel, there's a lot around pleasure, so maybe I'll start with almost a response to Anne. We actually have published the guideline on self-care interventions for health and well-being, which is the only guideline in WHO that actually has a recommendation around lubricant use for sexual health and pleasure across genders. So just to say, and a systematic review that was done around that. So Lester, when we spoke, said I should say a little bit about the self-care guideline, and then its link to the use of digital technologies, and then the private sector, and then ask questions. Right, lot to do in a few minutes. I'll try not to talk too fast, but this particular guideline actually has good practice statements and recommendations for digital health. So one around digital health interventions offering opportunities to promote, offer information about, and provide discussion forums for self-care interventions. This is for all individuals across diversity. Digital technologies for client to provider telemedicine to support self-care interventions that can be offered as a complement to face-to-face health services. And the third one, digital targeted client communication by health workers on the use of self-care interventions that can help to implement, monitor, and evaluate health outcomes. So these are actual, this is terminology within WHO global normative guidance. And so we've got this as a framework in the global guidance. How can we implement this, and what does it mean for sexual and reproductive health and rights? So a lot of the interventions are on SRHR, and the reason we have the second R is because this wasn't a guideline just about SRH. It's about placing it in the context of the framework that informed this guideline, which included that people-centered approach, the human rights, the gender equality, the enabling environment. So I'll just, because I don't have time to go through all of it, I will really encourage you to look at that concept, because people often say, well, are we just encouraging, self-care? Are we just giving a product to someone and then saying, now you're on your own? That's not how it was framed. And so the human rights considerations around this, and again, there's reviews published on this recently, actually 2 days ago, is that right? The editorial in SRHM, or one day, just in time for this panel, on the rights-based access to self-care, including with the use of digital health technologies. And so a couple of things here. And I'll just frame this as questions given the time we have. Firstly, is it feasible to do this? Can we offer these possibilities to people and communities when, for instance, we know there's like access to electricity, mobile phones, usability of devices, informed consent and privacy, and some of these issues that have already been discussed by certain panels. The second is who is accountable. We're talking here about the private sector, but who do we hold accountable for this, and how do we hold them accountable? So some aspects around that is where does the liability fall for when there's inaccurate information or false information or misuse of information or misuse of data? Where does that accountability fall, and how do we hold these people or governments or groups accountable? Fourth one is in terms of the right to equality and non-discrimination. Esther mentioned this earlier, but it's particularly relevant for underserved populations. And I heard mentioned here that we've included people, we've included communities. It's important to have the diverse voices. And I'm always, it's words that we all use, but there are certain communities and certain members that always fall through the cracks. And we need to acknowledge that. And when we get funding, we have a timeline for that funding, we need to provide results. How do we ensure that we have those diverse voices? And how do we ensure that their voices are actually heard, so that we can introspect, look back at whatever we have that's working, that's great, that's yay, and say, well, maybe we need to adjust this so that it can actually reflect their needs. And the panel I was in before was with Indigenous women with disabilities, women living with HIV. And I can, in my experience, and this includes with WHO, there are a lot of communities like this that are not meaningfully engaged. So when we're talking about access to technologies, access, private sector involvement, responsibilities and rights. I have 2 more minutes, 1 minute, half a minute? Yes, I'm finished. This is important. So that whole issue of equality and non-discrimination, the right to health, the right to participation, information, privacy, confidentiality, and then we talk about gender equity and rights in terms of technology is very useful when there's lack of access, when there's distance, the burden of travel for people, for instance, who are taking care of others. We know all this, but at the same time, are we also taking into consideration people who might have disability for hearing or for hearing impairments or digital literacy, visual or other disability. So again, technology plays a role. It's going to continue to increase. We see that. We're not here to stop that. But I think from WHO, the guidance and the guidelines that we're developing, the tools we're developing, particularly around self-care and placing those people-centered approach and integrated approach to sexual and reproductive health and rights, is really grounded on those principles, and that we don't move away from that. So every time we have some new funky technology or intervention or anything that we know it's safe and efficacious, that we also ground it in that safe, supportive, enabling environment and that rights approach. And we have the tools to do it. We just need to be able to ensure that we walk the talk when we do it. Thank you.
Any questions to Manjula? Any comments?
It's time for a drink.
Everyone's
Coffee.
tired. A long day. Ben?
It's a long day.
I have a comment for the panel. I want us to all think about how do we make it pleasurable for businesses and others in the private sector here to do the right thing? What is it that we can put in place that not just sanctions bad behavior in private sector, but that encourages and supports the kind of behavior we would like to see, the kind of outcomes we're all working toward? So I don't really have, it's a question, like what can we do and what can be done to help the private sector?
You need the lubricant of rights.
There you go. All right.
Anyone? Go ahead.
I just have a very simple answer that before introducing the business models, we need to talk. We need to sit down and assess the regulations and the policies, talk to the sex workers, talk to the adolescent, and then roll out the business model, because this is how you bring rights. It's not, I think, it's a kind of magic thing. I think it's talking and working together, because we have solutions, you have solutions, so let's bring it together. I'm sorry to be so simple, but I think it's pretty simple in that sense.
It's also about, I think for me, we're not bringing the solution to people. Yes, there in some elements we have to do that, but there are communities and people that can be, they have the power to make some of those decisions, and they should be making their own decisions. That it's not up to well-meaning agencies to fly in and help out. I think the whole conversation right now about the decolonization is really important, and I think that if we're really going to again walk the talk on that, it's really about making sure we hear people where they're at, and they, for centuries people have been, for instance, self-care. People have been doing self-care since the dawn of time. Like, they don't need for WHO to come in and say, hello, we've got a guideline. No, but it's helpful for the global public health to have that, but it's also important that we recognize that people have been doing, taking care of health. There are opportunities on the ground in every community, and we need to respect that and help that grow as well, instead of bringing something to people.
And any closing comments from you?
Are we finishing off now?
Yeah, we are going for a quick round of comments from each one of you.
Okay.
30 seconds each. She's staring at me actually there.
Well, ask yourself, are you pro-pleasure? Now you know that the evidence shows us that that makes your interventions more effective. This is not something that's frivolous. It's not something that's just fun. It's something that the private sector has known about for a very long time when it comes to other products. And when we're thinking about sexual rights, reproductive health, we also need to think about that. And that's becoming more and more pressing year on year as more people get access online, and they will just switch off from traditional sex education that focuses on fear or death or danger and disease, and they will look for alternatives that's freely available. So think about how you're going to make your content, your products, your clinics more appealing. And we need to choose a new path, which is not traditional sex education that focuses on fear, which is not the hypersexualized, sexist, racist narratives of what's available in porn, but a new path. And we have examples of that in the pleasure principles. Please go and see them, endorse the pleasure principles, and come along to our session on Wednesday.
Vitika, you want to make any comments before we wind up? You're good? Great. Thanks a lot, everyone, for sitting through a long day. And as still happens in our field, the Quality and Rights panel is always the last one. So just a reminder to next time integrate the quality and rights discussions within the approaches that are being talked about so that we're discussing them together and not as separate issues. The second thing from my observation of the literature that I'm looking at, donors are making very little investments to understand what happens in the digital space. You are chasing the measures you are familiar with. You are not asking what else might be happening that needs to be also understood much better. And finally, the realizing of rights is what must be at the heart of the digital, because that is at the heart of what sexual and reproductive health is about. It is unleashing the potential of experiencing more freedoms and more rights for women, girls, and communities. And what we seem to do is measure tactical wins of policies, tactical wins on scale, and not the deep structures of change that are required that builds for communities the potential of sustainable impact with rights in their lives every day. So I really want to kind of push us and say, is the informed choice measure, Ben, still a valid measure for our field when women are clicking on 40 sites before they make a decision on what they want? How do you attribute agency to that one site when it comes to your clinic, comes to your site? And this complexity has always existed for women. They learn from different journeys and different places before they make their choices. And yet we pin it down to a measure that is based in an analog world where someone is going to sit in front of you and talk to you and explain to you, tick the boxes and say, I've counseled you. So I think it's really time for our field to reinvent itself, both in the measurement space, but more importantly in the conceptual space of what does the digital mean to society. And the relationship between the digital and the analog is not a broken one, it's a real one still happening. So on that note, we're going to end. Thanks a lot to the panel, thanks a lot to all the panelists. Ashley, I think you need to say a few words.
I hope you enjoyed as I have. This is just to remind you about all other private sector activities that will be happening during the ICFP. You can just look at the private sector community of practice and you will see a cheat sheet of all of that. So thank you everyone, it was great, and that's all.